now we have a very, very important topic. Most of us are doing this surgery, small incision cataract surgery, and those who are working under high volume centers, they have to do this surgery in any case. Although everybody claims that they are doing just the phaco, but in our setup also we do around say 100 or 150 cataracts, and out of that all free. It's a government hospital. Still we have to do around 80 to 90% cases as SSGS. So we keep on improving on that, and we have such great faculties like Professor KPS Malik, Professor Ruchi Goyal, Professor Lahane from Bombay, Dr. SP Singh from Allahabad, Professor Ragni Parikh from Bombay, Dr. Pranav Saruja from Chitrakoot, Sadguru Eye Hospital, and myself, Kamaljeet Singh from Allahabad. So we have been doing this instruction course since long, and I learned all this from Dr. KPS Malik and Dr. Lahane, how to tackle difficult cases and how to do the routine cases that we do. So first speaker today is Professor KPS Malik. As you all know, he is living legend and he's the pioneer of SICS. So I invite him to give his talk on hard cataracts. Thank you so much. May I invite Professor Lahane sir to please come onto the dais, and Dr. Ragni Parikh and Dr. Ruchi Goyal, please.
इसमें सर टाइमिंग लगानी है कि नहीं लगानी है? क्या ये टाइमर 10 मिनट का कितने मिनट का लगाऊं? 8 का चलने दो, मैं तो बहुत जल्दी खत्म कर देता हूँ. तो स्टार्ट फ्रॉम हियर ओनली. इसमें ऑडियो भी है सिर्फ वीडियो चलाना यहीं से है ना? बस ये सब प्ले कर दी, चलने लग गई. हाँ बस इंटर अपना थैंक यू. दिस वन. Good morning. I am KPS Malik. I was in Sadhguru Hospital long time, professor and head. I was head for 22 years, and then I retired additional DG from Ministry of Health. I saw the Blumenthal long time back somewhere in Delhi doing it, then when we were doing phaco very well. And I saw it so impressive surgery that it really in a place where healing is much better than phaco. It's not clear corneal incision. It's an incision which is in the sclera, heals very well. And if you make a good pockets around in the cornea and sclera, then you can take any lens out of it and you can do it without suturing. So this is just a video of a cataract done by me. And you can see that black cataract, virtually black cataract. So this much hard cataract, if you try phaco, whatever is your machine, your cornea would not be happy. Your cornea would not be happy, and your iris also may be not very happy. Only thing about these cataracts and making this kind of incision, that curvilinear like this, and then pockets in the sclera and cornea. So that gives you such a big space, like a mouth of a snake, which dislocates mandible to eat the bigger things. Same way, we virtually dissect the sclera and cornea inside, and outside incision remain about 5.5. I never go beyond 5.5. And I call anterior chamber maintainer is the versatile instrument for even phaco. In a hard cataract, I will use the anterior chamber maintainer to control the surge. So you don't require any big machine for surge control. If your anterior chamber maintainer is giving you the fluid in the chamber, it is all the time full. And you don't require the surge controller or a very big machines or a very advanced machine. And see this lens. And you have a slight lens glide, but I have learned to do it with a iris repositor. And as soon as it shows in the mouth, I insert a needle and wheel it out. So you can see that such a big black cataract has been taken out of the small area. Anything about this? Anybody felt difficulty in executing this kind of incision? This kind of incision requires little experience in the sense, think that you can make on a paper these kind of charts, like children do, that you can practice this incision on the paper by pencil first, 100 times, that like this, like this, like this. So many times you do that on the paper, then your hand will work on the sclera also same way, that you take from here and go in one go. And first will be scratch. We say scratch is maybe half of the thickness of the sclera, but that is a little too much. Maybe 0.4, maybe 0.3. But half also is no problem at all. The only thing is that making it is the art. Making it the art, don't make it jagged, don't make it kind of a upar niche, and don't make it too superficial to buttonhole, and don't make it too deep to go into the chamber. So these are the two things to be kind of observed while making this incision. And then, of course, its rest is nucleus has gone, and the anterior chamber maintainer works like a irrigator, and you can use another probe from side port to take away cortex from everywhere. And then you can put a PMMA, but I inject lenses now, and you can inject any kind of lens. Bifocal I don't prefer at all. Bifocal is called multifocal also. I will prefer a good trifocal lens which has distance you can see everywhere. You can see your watch, you can see your hair, you can see distance, you can see sitting here. I can do that, blessed by God to see everywhere. So if you have to give the incision, give a horizontal incision, never a vertical incision. Vertical incision will induce the myopia in the vertical meridian. So never a vertical incision. And this figure of 8 incision start from sclera, take to this side of sclera, then this side of sclera and that side of sclera, and ultimately knot comes in the burial like it is in the incision. And then conjunctiva you can put back, and you can see the tunnel dissection. That is, once you make a proper incision, tunnel dissection is another art, that you keep your crescent knife, keeping in mind the contour of the cornea. Don't go straight. So you have to see the cornea is like this and then like this. So, and I make side port both sides, and especially I have published the bimanual rexis. So left side dialer manipulates the rexis, and right side do the rexis. So you can do the large rexis or any kind of rexis, but bimanual means my left hand is ready to spread it out, don't allow the freezing of the capsule, and this keeps a watch on the rexis left hand, that anywhere there is a problem with this rexis, it will spread it. It will spread it. So this was jumbling up what we call frozen rexis, and then with the bimanual rexis, you can get the absolute control onto the rexis. And then we enter the chamber with the 2.8 or 3.2 and cut going in. And when you do it fast. Quick, 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 so the chamber doesn't collapse. So don't allow the chamber to collapse. And then hard nucleus virtually occupying the whole space, and it comes out easily. And you can inject visco over it, behind it also. Once you get a little lifting of the nucleus, you can inject the visco under it also. So it will be separated from everywhere. And see, this is also very big nucleus. and very hard, virtually brown, grade 5. In fact, black cataract, sometimes which called black cataract, may be smaller than these ones, the brown cataracts. And antechamber maintainer is a must part of my procedure before the beginning. I can do the rhexis underwater also, that you have a rhexis under the antechamber maintainer fluid. So you don't use the visco. And visco sometimes get back onto the back of cornea and attracts lot of cortex and other things. So you can do the rhexis under the water. Assisted delivery I call like this, that under the iris repositor, I am giving a liquid push. The nucleus is being pushed by the fluid. And nowadays I can inject through the antechamber maintainer viscoelastic also. You can inject in a hard cataract little bit of visco through antechamber maintainer, and it will push it into the, see now, there's the biggest one come out of it. Thank you very much. I think this will take you to the, thank you so much. Thank you so much.
Thank you, Professor KPS Malik, sir. It's a wonderful technique of Blumenthal that you have shown to the audience. And you can see that the pupil keeps on dilating in between and the chamber always remains watertight. So these are some of the finer points that you have learned from Professor KPS Malik. Now I'll invite Professor Ruchi Goyal. She's also from Delhi, a pioneer in SICS, to give her talk, please. Thank you. And of course, a student of Dr. KPS Malik. He's so proud that he keeps on announcing this.
She's one of the best in the country now, for everything. Oculoplasty, now she is oculoplasty surgeon. And when she was a student, she did everything better than me. So you must have a student like that, and then you want to teach them really everything. So during my PG days, I cataract, glaucoma, ptosis, squint, except the retina, everything. I am the old timer from Sitapur. Everything except retina. 30 years back, I was doing retina also, those circlars, band and sponge. But nowadays, people have come to enter the vitreous, remove the vitreous, and do something. So maybe they are better off. But we were getting that time a retina settled and 30-degree vision always maintained. Yes. Go ahead, please.
So, good morning everyone, and thank you Dr. Kamaljeet sir for inviting me for this presentation. So, I shall be speaking on how you can manage a case of glaucoma with cataract. We all know we have, of course, options of doing a trabeculectomy first and then going for cataract surgery, but there would be cases where you have very high pressures with advanced cupping and you want to go ahead and do both the surgeries combined. So, just to show a couple of cases how we manage it, this technique is the flying incision technique which Dr. Malik only came up with the idea, and this is the kind of incision I'm going to use. So what I do is, after making a conjunctival peritomy, you have seen I've left a frill of conjunctiva close to the limbus, and this is the flying eagle shaped incision which we publish also, and this incision, it has a square, you can see the center has a square, the rest of it is round shaped, and then of course the incision and the wound and the SICS is as you do regularly. So these I like to make side port also in all my incisions regularly now, and this helps in, of course, not only the capsular rhexis, but in I actually have started using a bimanual during washing in all my cases. So this is the keratome entry, and after that the nucleus is brought out as in any SICS. So the advantage of this square-shaped flap here is that if you suture both the ends, it prevents the wound drag post-operatively, maintains the chamber and the flap, and after that, this is just to wash the chamber, because sometimes if your chamber is becoming too shallow again and again, if in a case where you already have a compromised disc, you do not want the pressure to rise and fall again and again. You want a constant pressure, so you can just put a suture, complete your wash, and then place your IOL in the bag. And once this is done, I don't use any Kelly's sponge. I simply use a MVR blade, and MVR blade is used to make a sclerostomy, and this is a 1 hour seizures to just cut off the sclerotomy, and then of course this is the peripheral iridectomy being done. So it's a very simple technique. I put 2 sutures on both the ends. As I said, this not only prevents the chamber from being leaky post-operatively, it also prevents against the wound shift, so astigmatism is less. And after suturing the conjunctiva the way I've done, you have a very good bleb post-operatively. So this is a case where you already have a pre-existing bleb. So here in these cases you need to change your site of incision. So this you have to change to the temporal. You don't want to spoil your conjunctiva pre-existing. Since it was a very hard cataract and I did not want to go in for a phacoemulsification, so I decided to go in for a SICS. These patients where you already have a prior surgery, sometimes you have a lot of synechiae formation like in this patient, and the nucleus may be difficult to prolapse out of the bag. Then the next step is to take it out of the section. Now this AC maintainer, because the wound was leaky because due to the trabeculectomy bleb, the pressure was not building up, so I made use of a this irrigating wire vectors to prolapse the nucleus. This is a very interesting case with a pre-existing bleb with an absolutely flat chamber. This chamber is actually totally flat. So there was no working space, there was no way I could do an SICS. But if you see, when I pushed the dye, the bleb was functioning, yet the pressure was very high. So how to manage this patient? The patient had only PL, the PR was also inaccurate, so I had nothing to lose. So what I decided to do, I first made side ports to push the viscoelastic. Still the chamber did not form. Then I decided to go in and do a little bit of core vitrectomy. So this is a port 3, this is 4 millimeter pars plana infusion being placed. Little bit of vitrectomy was done, and because of this, the chamber, after this, the eye becomes soft, and I put in the viscoelastic, the chamber was formed slightly. Then I put in my vitreous sweep, and I created, released some of the synechiae, did my rexes. You can still see the cornea is pretty hazy, chamber is still very shallow. Still there is no scope of doing a SICS. You can go for an ECC, but SICS no. So now I decided that I'll do a in the bag phaco. So this is a direct job being done in the bag, and the moral of the story is you need to know all surgeries to to handle all these kind of cases. So this is just because there is no space in the anterior chamber, so you have to do an in the bag phacoemulsification, and that also a direct job. You cannot go for a stop and chop. So after doing this, the chamber deepened a little more. Now you can see the things are a little better, and I implanted a IOL within the bag. Again, it was not with high pressure, such shallow chambers. If you open up and you try and put a bigger lens, there are chances of expulsive hemorrhage. So I didn't want to open the chamber further. And now you can see the chamber has formed, and these are the pars plana infusions I've removed, done a vitrectomy, and actually this patient got a 6/12 vision after the surgery. So never give up, keep trying whatever you can. Many patients with glaucoma, they may present with PR inaccurate. Classically in the books we have been told that if PR is inaccurate, you are not going to get vision. I've seen patients who actually present with PL negative, and we have been able to save those eyes. So never give up. That is my principle of going about. You can of course talk to the patient that nothing more is to be lost, but at least give one try. So this is how, why this patient had a a very good bleb, yet the chamber was flat, was possibly in the post-operative period, whoever had did the surgery never bothered to follow up the patient to ensure that the chamber was formed in the early post-op period. So possibly the peripheral anterior synechiae had formed, and the patient developed this kind of a condition. So I think, thank you so much. I will be very happy to take any questions. Thank you.
But Professor Ruchi, you thought of not doing the iodectomies, PIs, 1 or 2, 3?
Sir, already the trabeculectomy was done and the PI was already there.
One PI.
So that's enough.
But you never thought of adding the iodectomies?
Sir, there was no need for that. The problem was that there were total posterior synechiae all around. So probably the entire angle at the periphery was blocked because of the Seneca formation. Otherwise, the fluid was functioning. You could see the dyes going through it even
Wonderful.
before I entered the chamber.
Very good and very difficult case, and we should applaud that. And now we have the titan of the ophthalmology, the Professor Lahane. He can do anything. मतलब like कैटरेक्ट ग्लूकोमा के अलावा मारपीट करना हो, कुछ और करना हो तो वो भी वो कर देते हैं. वो हम जैसे लोग कुछ गांव वाले ऐसे हैं, कभी कभी करना पड़ता है, कोई बात नहीं है.
True.
तो we have the like Professor Ragini, Professor Kamaljeet, Professor Ruchi. These people are master of FECO, in fact, and they started SICS after that. But SICS is such a saving grace sometimes that your FECO can ruin your life with the cornea, with the iris. So such cases, SICS, I believe that everybody must learn. And I would say that if your really FECO is not going to help this patient, it's much better to make the incision of SIC and then enlarge it on the right side from the flap to the limbus so that it becomes ECC in a way that you can bring out every lens.
No,
But your tunnel will remain intact. You might have to suture the extension. That's all. And don't do extension on either side. One side extension is good enough from the flap to the limbus, and then your whole nucleus can be taken out. Your tunnel, which is frown, will remain intact, and then you can give a suture on the extension. So these people, you can ask anything, anytime, wherever you meet, that what is the problem you are facing, they will tell you on the way. And while eating khana also they will teach you, if you want.
Thank you.
Professor
Thank you, Kamaljeet Singh, Malik sir, Ruchi and Dr. Agini. Thank you very much. My topic is small incision surgery. Like Malik sir said, there is no any difficult situation for the SICS. So difficult situation is there for the phaco surgeon and not for the SICS surgeon. So be phaco surgeon, but be SICS surgeon. So that sometimes the SICS will save you. So you can see the corneal opacities are there, and in this, if there is a cataract, phaco will not work. And then they go for the endo illuminator, then the exo illuminator, then so many illuminator, and after that nucleus goes behind. So it is better to go for the SICS. And see the, you can do the two things, keratoplasty followed by cataract, or cataract with iridotomy, or cataract with keratoplasty. So you can have so many options. You can go ahead and do that. So now if you see the visual rehabilitation when you do such type of cases, because there is a corneal opacity, then when you are doing the endothelial loss, you can't see, it's like a blind procedure you are doing. Then when you are doing two procedures together, the rejection chances are much more than once you are doing only the transplant. Now second thing is, in India, you know, there is no good donors. So donors are the old people, and because of that, cornea quality is not good. And when you are doing the such type of cataract, then the IOL calculation, no formula works. So there is no any formula which works for this. So you can go for the keratoplasty followed by cataract if there are difficulties. And the other thing is, this is an old method where you can do it. See, does not provide clear visual axis. Always the axis is eccentric here, because since beginning patient is having the corneal opacity, and this compromise the binocularity in such cases. So cataract with iridotomy you can do, and then you can see cataract with keratoplasty, triple procedure. Here, as you know, the visual rehabilitation is delayed as cornea is changed. Risk of endothelial loss, anterior chamber reaction, you will get the refractive surprises, and the paucity, as you know, the donor is not properly there. Then you can go for cataract surgery issue in the corneal opacities. If you are doing the cataract surgery, then the visualization is difficult. The posterior capsular tear you may not see, and it will happen. The cortex, it is difficult to remove the cortex. The refractive surprises after that, because A scan may not be correct, so you may get the surprises. And the surgical time, it may be a prolonged surgical time may be there. अरे वीडियो क्यों प्ले नहीं हाँ इधर वीडियो रे ओनली पीछे पीछे जा वीडियो ओपन हाँ ये वीडियो ओपन करना है हाँ हाँ खोलेगा ना हाँ
वीडियो आपको जैसे ये रन कर रही है ये मूव हो रही है
अच्छा फोल्डर में करना पड़ेगा एक मिनट इसको एक मिनट ये ना हाँ एक मिनट वेट कर रहा हूँ
अलग से वीडियो ऐसे
हाँ एक मिनट देख रहे चालू करके हाँ
लोडिंग हो रही है सर
हाँ
अलग से वीडियो है तो मैं वो प्ले कर दे रहा हूँ दोबारा से लगा दे रहा हूँ क्योंकि इसमें ना टाइम लगेगा
हाँ
जो आपने इसमें वीडियो ऐड किया ना
प्रॉब्लम इज देयर सो ओके हाँ चालू कर okay. Now what happens, we give steroid and you get the opacity and also the subcapsular cataract. The video is not running, I think there is some problem in that. So in such cases, you can do the, there is a limbitis also, and ये कौन सा लगा है? नहीं, कुछ दूसरा लगा है. हाँ? नहीं लगी नहीं. हाँ. हाँ. So you get the pterygium also, that is like an opacity. So there is a affection in the topography, and see the how the topography is affected, and in such situation you can go for the pterygium first, and after that you can go for the cataract surgery. So always remember, because the astigmatism because of this pterygium will be difficult. See, the pterygium surgery is done, and after that the SICH is done. I use the Blumenthal technique, where I use glide, and in the glide I remove the any type of nucleus like Malik sir was doing. Thank you very much. I think there is one more case. No, it is. You can see the trauma, then there is a suturing is done, and in that now I am doing the इसको बंद करना है, आवाज़ से बंद करना है। हाँ बता रहा हूँ। So you can see the rexis is done. इसको बंद करना है आवाज़ को यहाँ से 1 minute. हाँ okay. So you see this, the rexis is done, and you will see now the visco expression. The visco expression is done, and then the aspiration cannula, this we have devised. It is a sand polished aspiration cannula that can be used on any side. So because here the side port required in this is only 1.1, and so we use the aspiration cannula like irrigation. We are using bimanual in phaco. So AC maintainer with aspiration cannula, and then now I am implanting the lens. You can see it is in the bag. दूसरा वीडियो नहीं है. So you know the cataract, you'll have to see, and accordingly then you can improve yourself. And if you do it properly, you can succeed. Thank you very much.
So Professor Lahane does lakhs of surgeries in fields for so many years.
कहाँ है इसको? हाँ.
Professor Lahane sir, you can see all kinds of cataracts, whether with corneal opacity, glaucoma, or hard cataracts, soft cataracts, all can be removed by SICS technique. So now we have, I invite comments from Professor Malik, please. And the next speaker is Professor Ragini Parekh, please.
Dr. Ragini Parekh is again a versatile professor. Means they teach people and they teach students and they teach us also. And she also does phaco and
ये खुलेगा.
SICS.
Thank you, sir. Thank you, sir. Respected Professor Malik, sir. Padma Shri Dr. Lahane, sir. Professor Dr. Malik, sir. Professor Dr. Ruchi Goyal, sir. So like Dr. Malik, sir said that everybody is a phaco surgeon, but like Lahane, sir always says and Malik, sir always says that out of the lakhs of surgeries that are done in India, majority of the surgeries are SICS. In a subluxated cataract, we were always worried whether we would be able to do IOL implantation. Otherwise, in the past, it was always an intracapsular surgery. What causes subluxation? It could be trauma, previous ocular surgery, multiple intravitreal injections, Marfan syndrome, homocystinuria, pseudoexfoliation, Weil-Marchesani syndrome, sulfite oxidase deficiency. These are some of the causes which cause subluxation, as we all know. There may be a stable subluxation or it may be progressive. The management would differ in those cases. So trauma and previous ocular surgery, multiple intraocular, we have already seen this. So these would cause progressive and generalized weak zonules. How would you manage the case of subluxation? It is very important to investigate and examine the patient properly. A pre-operative precaution. So when you are examining the patient on slit lamp, you have to measure the amount of clock hours of subluxation, and one must always remember that that subluxation which you see intraoperatively will be more than what is seen on slit lamp. You have to take pre-operative precautions. The counseling of the patient is very, very important. Intraoperatively, the procedure will be different than your standard SICS because you may have to use devices. There will be an extra intraoperative time, and post-operatively, the patient will require steroids or close monitoring and management. Even after the post-operative period of 6 weeks is over, you have to observe the patient closely for secondary glaucoma or decentration of the intraocular lens. So all these factors are very, very important. Continuous monitoring of the patient to examine the retina, because whatever caused the subluxation could have also involved the retina. So these are very, very important. slit lamp examination, UBM examination, B-scan sonography, retina examination. These are also important from the patient point of view and also important from the medical legal point of view, where you have to document everything, because the patient is very sweet when he comes to you, has a lot of expectations, and later on he may create a lot of problems. UBM is a very valuable tool today to UBM is a valuable tool today to, there is one slide which is not seen only, okay. So preoperative counseling, like I said, is extremely important. Explaining to the patient the need of complicated or prolonged surgery, the need for a vitreoretinal surgery or a vitreoretinal surgeon standby, the risk of retinal detachment post-operatively and or cystoid macular edema. So all these needs to be explained to the patient, because when you are in the OPD, you have 4 or 5 patients and they come for follow-up at the same time and they will discuss ki mere ko to ye drops diye, I have not seeing so well. So all these are very, very important. Intraoperatively, also you have to be very careful as to there may be a problem and how will you manage. So if there is a zonular dehiscence up to 4 clock hours, you will use the CTR with an IOL implantation. Up to 3 clock hours, again CTR with IOL implantation. Greater than 3 to 6 clock hours, modified CTR with a single loop. Between 6 to 9 o'clock hours, then a double loop CTR or some modified devices with IOL implantation. And very large subluxation, you may defer the in the bag IOL and you may prefer to do a SF IOL or iris fixated lenses. So that is why the number of clock hours of subluxation is very, very important. Now, when you are planning the incision, normally you would do a superior or a superior temporal incision in SICS, which is good because it is covered by the conjunctiva and the upper lid. But you won't try to place the incision away from the zonular weakness and opposite to the zonular weakness if possible. If not possible, because you can't do an inferior incision, you can't do 2 temporal and incision in a complicated surgery. So you should not jeopardize your ability to try to do acrobatics. You have to do it in the most reasonable and the most scientific incision location possible, and then manage whatever comes your way properly by keeping a vitrectomy standby. Viscoelastic is very, very important, because here you are going to manipulate. You must remember, when I was learning, Dr. Lane sir always told me, and Dr. Patel sir, my teachers, that treat the cornea like God. Because if you are doing a good surgery, it may look very good on the next day, but if the endothelium is compromised slowly, it will decompensate. So you have to treat the cornea with a lot of respect, and you have to use a good viscoelastic. Capsular rexes here will be, because the capsule will be loose, so you have to be, you have to plan, so it is better to stain the rexes. You can use forceps and needle so that you have better control, and that is why it is very important. Now, one thing you must remember is that the lens is subluxated or decentered, so the rexes should be centered on the lens and not in the center of the pupil which is dilated, because ultimately you will be fixing the bag. So the rexes should be centered on the lens, one must remember that. So as you can see, this is a subluxated cataract. The capsule has been stained. The incision is a sclerocorneal tunnel. We are now doing and centering the rexes on the lens. And as you can see, the lens is very considerably subluxated, so making a small rexes and not going too near the area of subluxation. So there the rexes is not very large, and one is successful in making the rexes after the tunnel has opened. Hydrodissection, you have to be very, very careful while doing these hydro procedures, because it can cause amount of fluid inside the bag and the bag to subluxate more. So one has to be very careful. Small amount of fluid in multiple zones is very important. Orientation of the IOL. Now, when you are using a rigid IOL, the size of the IOL is big, and with the haptics you can enlarge the bag, it can be centered, it can be positioned. So these rigid IOLs are a boon, and you have to manage to put the IOL in such a way as to inflate your bag and to center it. So that is very, very important. So there are 2 schools of thought: in a plane parallel to the zonular dialysis, or in the area of zonular dialysis, one haptic. So stretching the bag is very, very important. Capsular tension rings have been a boon because these were the ones which helped us make this into an extracapsular surgery and not an intracapsular surgery. So there are various types of rings and sizes available. When you measure the white to white in a patient before surgery, you would be able to judge the size of the ring that would be required in a particular patient. Now the CTR, the time of insertion is before the removal of the cataract or after the removal of the cataract. One has to customize it according to the case, and you have to insert it in such a way that you hold one and you use specially designed forceps to insert the ring. Now, as you can see over here, this is the CTR ring. You are holding one edge and you are inserting it into the other under the capsule. So it goes inside the bag and it rotates because it is circular. So you have to gently put it, and then when the end is there, you put the dialer inside the loop or the hole which is there and put it inside the bag. You have to be very, very careful because in lots of patients we have found when we were doing a second vitrectomy surgery for a patient, 2-3 CTR rings in the vitreous with one more IOL in the vitreous. So it should be done only when you are comfortable and you are able to do it. So it can be done before phacoemulsification or before SICS nucleus delivery, or it can be done after nucleus delivery, whichever is comfortable and whichever is important for that patient. So if you're doing it after nucleus delivery, it should be stabilized till nucleus management. You can stabilize it with iris hooks and it can be inserted with simple forceps. Correct? So what are the contraindications to a CTR? If your rhexis is broken, if there's a PC tear, if there's extensive zonular weakness, otherwise you will have the CTR inside the vitreous. And so that is very, very important. So this is the rhexis. You can see the subluxation and the crenated margins where it makes evident that the nucleus is subluxated, making the rhexis again important to be centered on the lens and not in the center of the pupil, so that you will be fixing the black and then it will be centered. We've already seen the placement of the CTR, but we can see it once again because it's a very, very important step. It needs a little bit of technique to put the CTR. It is not very difficult. One must remember that it is circular while inserting it, and you have to, it spins and it goes circularly inside the bag. Once you are used to putting it once or twice, then I think it is easy to learn how to put it. So once the CTR is in place, as you can see over it, the bag is already stretched and extended, and then after the removal of the cataract, it's very easy to put in the IOL. You can see the CTR. Here the IOL is being put with the AC maintainer in place and dialed. So the CTR, what it has done is it has enlarged or centralized the bag, it has supported the bag, and it has inflated it so that the position, there is ease of putting the IOL. Now, post-operatively, you have to monitor the centration of the IOL. You have to remove, post-operative means in the period during the surgery, you have to remove the viscoelastic. You have to check the shape of the pupil. If you have to see whether there are any vitreous strands and manage it by doing a vitrectomy or staining it with triamcinolone acetate, you have to monitor the intraocular pressure post-operatively. There will be pseudophacodonesis if the subluxation was large, and that itself will cause cystoid macular edema. So preventive measures by giving NSAIDs is important because cystoid macular edema in the long term will cause cystoid macular degeneration and a drop of vision. Retinal examination, because you have done so much of manipulation with putting in the CTR rings and removing the cataract and all that, so you have to see the retina very, very well and keep an eye on the retina so that you may not have any other complications. Patients have to be explained the need of closer follow-up. So you can give very good results in a subluxated cataract with proper planning, a proper expertise. And I would always say that I started doing all these cases after a reasonable amount of expertise, because there is no point in messing up a patient in the earlier on stage when you're doing SICS or surgeries. These patients can always be referred to a senior surgeon, because ultimately at the end of the day, the patient and his vision are important. One mess, it is very difficult to salvage an eye. but at the same time, starting with a small subluxated cataract with a small zone of subluxation where a CTR ring can be pushed, can be managed. Thank you so much, sir. Thank you, Kamaljeet Singh, sir, for giving me this opportunity to present the case, present with such stalwarts in SICS, sir. Thank you so much.
Thank you, Dr. Agni. And now I will call upon Dr. Kamaljeet Singh, sir.
Sir. So Japan blue has been known in many cases, even in mature cataracts, to stain the vitreous. But once you put the trypan blue and stain it, you cannot be sure that it will go behind. There are cases even without a subluxation in a mature cataract, when you are giving a wash, you see some amount of blue staining. Diluted trypan blue would be safe. And I think that the vitreoretinal surgeons, I think Pranav would be able to say, that they use trypan blue to stain the ILM also while doing. So I think that trypan blue which they use would be safe to use, sir. Thank you, sir.
Just
She knows about CTR load, so she might.
Just
comment more on
one small more tip. You can use an injector to put in the CTR. It's just 200 rupees injector, which you can use multiple times after autoclaving, and that really, bypasses all the stress of putting the CTR in the back. You just put it, bang into it, inject, it opens up. Madhu Instruments, no financial interest, Madhu Instruments.
Thank you, Dr. Ragni, making the subject, difficult subject it is, and CTR rings and Sioni rings, Dr. Ruchi is the master, she does so many of them. But, you must be careful about dye, I'll say that, 0.06 dye which we make, I inject directly in the aqueous and then wash. So little bit staining is enough. You don't need it to keep it for a minute or 30 seconds or 10 seconds.
Computer on laga.
So, you can just inject in the aqueous directly and wash within a few seconds. It will give enough stain for access. And if it goes behind, it doesn't do harm, that percentage. And Sir Kamaljeet Singh is a Neta of UP. And he, in Allahabad Medical College, a long time, he has been teaching, hundreds of students are out in all countries. And sir has a book also, Small Incision Cataract Surgery. And sir is a very gentleman.
It's all your blessings, sir. Blessings. Although I have white hair, sir has black hair. And he's young at heart and mind and body also. So thank you so much, sir. I'll be discussing with you a little bit about 6 in difficult situation, and I find Raju Ash also coming to the audience. Thank you so much. He's from Allahabad. So he has done thousands of SICS. So he's one other experienced surgeon here. बढ़ नहीं रहा यार ये. ऐसे ही चला है. ये तो बाद में हो गया. So this is तुम अपनी कर दो present. And we were waiting for Dr. S.P. Singh. He has always arrives at right time. So he can manage the trains and flights also, so that he can come on time. So, ठीक है. So what we do here is slight change in the, and this is a hard cataract, and what we are going to do is there were a lot of capsular synecdoche with the nucleus in this case. So you must have seen people doing synechotomy in the iris. But here what we have done is that we have separated the capsule from the lens because it was not moving at all. So after doing capsular access, we do hydrodissection as usual, and we found that the lens was not moving at all after doing lots of hydrodissection. So you can see we are doing you can see the iris spatula is there between the lens and the capsule, so that it separates from the nucleus. Otherwise it might, if you try to keep on rotating it, after too many times of hydrodissection, you will find that whole bag will move and you will create a intracapsular surgery or zonular dialysis aphakia, proper aphakia. So you can see that I am doing it from all sides, all around. So this side has been done, and then we do hydrodissection and lift the nucleus from one side and then break it into two, and we do the surgery. So this is one technique that can be done. This is a mini nuke technique. This is a hypermature cataract, you can see. So what we do here is, after doing capsular access, we try to remove the cortical matter and a little bit of epinucleus, and after removing that, we make the nucleus into a small nucleus. This was described long time back by Dr. Mulubenthal. So those days we used to do mini nuke technique to in order to reduce the size of the nucleus. So you see I have done reduce the size. Still there is, you see I am trying to remove the cortical matter from sides, and the nucleus has been made small, slightly small, and then you bring it out into the anterior chamber, and you can do a phacosection like this, irrigating vectis at the bottom and dialer on the top, and you can take it out in two pieces through a small incision. So this can be done, and then you can implant the lens. This I have already shown. And sometimes if you don't have the iris hooks, you don't have the BX, you don't have Maligian ring, then at times the sphincterotomy works very well. There what you have to do is that at the pupillary margin you have to just give a small nicks, 3-4 nicks, and you will find that your pupil will dilate. So I make side ports on both the sides, and you can see with the vanas a small nick is given in the lower portion and then on the side, and in this way you can give multiple this thing, and your pupil will dilate a little, and you will be able to perform the surgery easily. So you can visco express, like in this case we have visco express. All techniques can be used, and if in this case the nucleus was not coming out, so we have taken the irrigating vectis and done the job. So then you implant the lens. In a small pupil like this, which I learned from Dr. S.P. Singh, he has thousands of small pupil in his hand, in his videos he has done. So you can see this is a side port that have been made. 4 side ports are made, and you can see that I'm trying to do the synechotomy, but membrane is thick, so using vanas to cut the pupillary margin so that the nucleus is, and now we see that the pupil gets dilated. Still ultimately I found that the pupil was not good enough, so we put iris hooks to dilate the pupil. It's very easy. Initially when I did this surgery about 10 years back, then I thought that iris hooks might come out with the irrigating vectis, but it remains stationary and quite strong and does not come out. So you can see that it's a small nucleus, and just visco expression would remove the nucleus, and then you clean the cortical matter and epinucleus, and you can see it's quite a good dilated pupil, and you can wash it properly and implant the lens. Now, in case of pterygium, it's a simple surgery. You do first SICS, and you look at the astigmatism. Most important thing here is looking at the astigmatism, and based on astigmatism, you give your incision. So if it is steep at 12 o'clock, you will give there. If it is steep on the other side, then you will give the incision there. And after completing the SICS, then you can perform the pterygium surgery without any. There are synecdoche also in this case. So we are trying to do synechotomy, and a large incision is recommended because the nucleus is big, and you rotate it. Many a times you can rotate the nucleus even in a very, very small people. Sometimes you keep on rotating it, it would come out, or you can use a tumbling technique also if you have performed a good capsulorhexis. So here I am doing a can opener because the nucleus was not coming out, and slight rotation, it becomes much easier to bring the nucleus in the anterior chamber. And then you keep on doing hydrodissection and use lots of viscoelastic, and finally you will be able to take out the nucleus. You see, it has come out with visco expression. So this is what we do, and then finally we would do a pterygium surgery after putting the lens. Now here the chamber gets closed and you can perform the surgery easily. There are surgeons who perform at the same sitting. There are surgeons who perform pterygium surgery before and look at the evidence of astigmatism, how much astigmatism remains after the pterygium surgery, and then you finally do the cataract surgery. In subluxated cataracts also you can do SICS without any problem. Here a small technique we have adapted is that we have not taken the nucleus out, but before taking out the nucleus, we have implanted the nucleus beneath the cataract, so that because it's subluxated lens, the IOL acts as a CTR also. So you put the this non-foldable lens, so it would act like CTR. It will stretch the capsular bag, and there would be no problem in. So there was a subluxation in the inferior portion. So what we have done is we have not taken out the nucleus. No, this is the different case. So this is one case where we have just done the simple technique. And this is another case where we have done the AC IOL implantation. You must have heard about, we'll be having a course just after this of retropupillary IOLs and scleral fixated IOLs. You can do a good AC IOL implantation also. Only thing is that the size of the AC IOL should be proper. The problem, so you take out this nucleus. Everything went smooth in this case, and we found that there was corneal opacity, and we thought that there is no PCR, the visibility was not good. So when we tried to implant the posterior chamber IOL, we found that it was tilting. So we removed that. You see, it's going smoothly, but the moment we tried to rotate it, then we took it out and implanted a AC IOL and put a stitch there as recommended. So even AC IOLs can do a good job even in corneal opacity, and patient is able, one-eyed patient would be able to see better. And with SICS technique you can do IOL exchange also. This was a case who is a technician for ophthalmic instruments. His surgery was done and post-operative refraction was +3. So he came to me and said, sir कि मुझे पहले तो सब कुछ दिखता था नज़दीक का, बिल्कुल नहीं दिखता है, क्योंकि +3 and addition of 2.5, that makes 5.5 for him. So he came to me, I made him a little myopic and exchanged the lens after giving a good, because it was a non-foldable lens. So on the steep meridian we gave an incision and took out the lens. It's easy to take out the lens, and once it comes out, you can simply implant it. Take care that you don't rupture the posterior capsule, or you don't take out the bag with this. It was not a very old case, so we could easily implant the lens in this case too. So these are some of the cases that I wanted to share with you all. Thank you so much.
So we have Professor S.P. Singh, is from Allahabad, head of the Medical College Eye Department and director of Regional Institute of Ophthalmology. And principal and everything of the dean also. So he has taken over the Rajdhani from Kamaljeet Singh. Dr. S.P. Singh will tell you about pupils, small pupil that you can manage. And sir, now we are keeping a tag on the time. Now we have the one handsome speaker still waiting.
Okay,
For now.
sure.
Yeah.
Thank you so much. Good morning to everybody. Actually, I missed some of the important talk of our respected Dr. T.P. Lahane, Dr. Malik, Dr. Ruchi, and Dr. Ragini. But anyway, I was late little bit, but thank you so much. Thank you, sir, for giving opportunity to say my experience. Already, Dr. Kamaljeet has spoken some of the video of small people, maybe repetition of some of the cases, but anyway, have some own technique, some of the cases. I'm going to demonstrate directly to the videos of different cases. Okay. So, as you know, small people pose a great challenge to the ophthalmic surgeon because nothing is visible. You can see this is a there's no connection.
डिस्प्ले सेटिंग करना
Can I give my own this one, doctor?
एडिटर नहीं चाहिए सर डिस्प्ले सेटिंग में चाहिए सेटिंग्स का इसकी सेटिंग
Chalo, jab tak, if there's a problem, Dr. Pranav can speak. We have a computer, but he is a handsome bhatija of mine, son of Professor Kamaljeet. And so he's like my son also. And he's a very smart young man and very handsome, and he will be much handsomer if he shaves. These boys with dadi, I don't like them. These days, all of them have dadis. What is this fashion? Who started it here? Shah Rukh Khan, badmash. किसका जिसका पहले चल जाएगा चला जाएगा ये दाढ़ी का फैशन किसने चलाया था किसी को पता है क्या नहीं You ready, beta? Start.
So at the outset, I would like to thank all the eminent faculty. Dr. KPS sir has been my head of the department earlier also, and Dr. Lahane and Dr. Ruchi ma'am and Dr. Agni ma'am, all of them are very close, and obviously my father and Dr. S.P. Singh was also, I was trained under him during my senior residency days. So I would like to speak about astigmatism management in MSICS. As we all know that ophthalmology has grown by leaps and bounds, and it is not only our duty to improve the patient's vision but also to refine it. And proper management of astigmatism can lead to excellent visual outcomes. So the main aim is to achieve emetropia. So what are the goals of the surgery? Mainly it is painless visual recovery, spectacle independence. We have to correct all the pre-existing astigmatism, repeatability of the surgical result, the surgeries that we are doing, and give a sustained quality of vision to the patient. So we'll go to the basics. What the types of astigmatism, as we all know, is with the rule and against the rule. Against the rule is the one which we deal with in our patients when we are operating in cataracts, because the older patient have against the rule astigmatism. So what are the factors affecting astigmatism in SICS? It is mainly incision characteristics, use of cautery, and use and non-use of suture. Okay. And we will deal with each of them later on. And the important thing is that a proper pre-operative assessment of pre-existing astigmatism is very important. So how do we measure the astigmatism? We can measure it with retinoscopy, keratometry, and recently what we use is corneal topography. But still, in manual keratometry has still a lot of role in patients where there is poor fixation, corneal abnormalities, distorted Myers, high toric cornea, and dry cornea. In rest of the cases, we usually go for topography. So how do we correct the astigmatism in SICS? Mainly, incision characteristics is very important. The size of the incision, the larger the incision, the more the astigmatism can be corrected, and the more the astigmatism is caused also. So the smaller the incision, the lesser the flattening and lesser astigmatism cause. So the other thing is that the distance from the cornea, the farther the incision from the cornea, the lesser the astigmatism, and vice versa. The closer the incision, the more the astigmatism. So this was based on a theory which was given by Cox, and the target is to hit the astigmatically neutral zone. So what was stated was that surgically induced astigmatism is directly proportional to the length of the incision to the power of Q. And the theory is that the funnel's base is at the limbus, and as it moves away, it widens. So the incision should be made between this to give an astigmatically neutral result. So the next thing is incision type. There are multiple incision type. We can go for a superior incision, temporal, or superiotemporal incision. Superior incision is the one that we usually go for in post-graduation because it is easy to learn. There is more wound protection and lesser foreign body sensation to the patient. In temporal incision is the one that we should go for because we want to correct the against the rule astigmatism in these patients. And also it is easier in deep sockets, and the most important thing is that in future trabeculectomy patients also the conjunctiva is spared. So this concept is also based on coupling, and it states that flattening effect is achieved at the tissue and steepening is produced 90 degrees away. So this gives an astigmatism of around -1 to -1.5 diopter at 90 degree if a 6.5 millimeter incision is placed at 12 o'clock. So when we flatten one meridian of the cornea, we steepen the other meridian. So we should always keep that in mind. And this was a study done by Gokhale et al. And they stated that superiotemporal incision was the one which gave the least astigmatism, which was around 0.2 diopters. And the rest of the superior incision, as we've already talked about, gives the most amount of astigmatism. So it is better to go for a temporal or a superiotemporal incision if we are thinking of correcting the astigmatism. And the length, as we all know, this is the amount of astigmatism that is usually caused, but it is mostly related to the surgeon. So the other thing is cautery. In SICS, we do use cautery. At our center, we usually do not use cautery. But if we are using cautery, we should be very careful because it may cause scleral shrinkage and scleral necrosis, which may result in more astigmatism. So how do we correct this pre-existing astigmatism? For mild cases, we operate on the steeper axis, as we've already talked about. If it is against the rule astigmatism, we operate on the temporal side to correct the pre-existing astigmatism. And this is very important. We should keep it in mind. Even in phacoemulsification, we usually operate on the steeper axis. We see from the corneal topography, and we go for the one which is steeper. So the other thing is going for a limbal relaxing incision. Usually a 90% depth is there in these incisions, and it is just given in front of the limbus. And it should always be given on the steeper meridian, as we've talked about. So this is a case where we gave limbal relaxing incision just to cancel out the incision that we made. So a superior incision is being made. We usually make the tunnel, but we do not enter the anterior chamber right now. After that, We usually have a guarded knife, which almost gives around 600 micron of depth, and we just give it in front of the limbus. So we usually give a paired incision, we can give another incision on the other side. So that depends on the amount of astigmatism that you have to correct. And this, there are multiple nomograms which we can use by Miller, Gill and Nichemin. And also there is an online calculator with which we can get the amount of astigmatism that we want to correct, and they give you the amount of incision that you have to make. So these are the Miller's nomogram usually states that usually 1 clock hour of paired incisions of 1 diopter of corneal astigmatism will be cured. And this varies with the patient's age. If a little larger size of incision is given in a younger patient, and little lesser in the older patients. So other nomograms have also been given, which may help in deciding our surgeries. And this is also another LRI which states how much diopters you can correct, and it is a very easy nomogram to learn. So what are the advantages of this? It is mainly that it gives a lesser tendency of shift in the resultant cylindrical axis, and irregular corneal flattening and irregular astigmatism is prevented, which may be more for a arcuate incision. The other thing is that it is easier to perform, and the length is shorter and centrally rather than the centrally placed corneal relaxing incision, and it gives a consistent coupling ratio, which is very important. So the other concept is opposite clear corneal incision. This was a concept given by Liver and Dan, and they modified the standard approach of the clear corneal incision, adding an identical incision on the opposite end. So this usually corrected 1.66 plus minus 0.5 diopter of astigmatism. The technique involves creating 2 biplanar incisions, but in SICS we can just add another incision on the opposite end wherever we are operating, just to correct the amount of astigmatism that we want to correct. So the problem with this is that there is lack of predictability and absence of nomograms, but it usually corrects around 1.5 diopter of astigmatism. So in summary, if there is preoperative astigmatism, in cases where there is less than 1 diopter of astigmatism, we can go for a frown incision, which is 3 millimeter behind the cornea. If there is moderate, we go for a small incision centered along the steeper meridian, and a straighter incision will correct more. And if there is higher astigmatism, we go for a combination of small incision profile, like giving a straighter incision, a larger incision, and also adding LRIs or opposite clear corneal incision. And in post-operative, we can go for astigmatic keratotomy, wound revision, excision laser. So the take-home message, as we've talked about, we should always operate on the steeper axis to prevent the surgically induced astigmatism. And there are multiple techniques which we've already talked about. We can combine multiple techniques to give better results. Thank you.
Pranav?
Thank you, sir.
We invite Professor S.P. Singh now for his the last speech. And Pranav has talked about these astigmatism can be corrected by SICS only. These many astigmatism cannot be corrected ever by phaco incisions, phaco ones. And these days, dry eye is a rampant epidemic in the world. So better in phaco also shift back little incision on the limbus with blood vessels and not the clear cornea. Found that clear corneal incision induces more dryness. Yes, sir. 5 minutes plus 2.
Sure.
Yes.
As you know, the small people pose definitely a great challenge to ophthalmic surgeon, because in the small people most of things are not visible. So how to make it a little bit expose the posterior part? This is the. So I'm directly coming to the video because already the session is late.
अभी late नहीं हुआ, अभी ठीक चल रहा है.
Thank you so much. So can you see this case? How much the people, a lot of synechiae is there, this pupillary membrane is there. So first you have to remove the pupillary membrane. How you can remove? Just make a paracentric support, and then the micro scissor you have to cut the margin all around the pupillary membrane, all around the this pupillary border. That is known as pupillary edge. So you can see the whole this pupillary area is covered with this thick pupillary membrane, and then hold it with the sedated micro forceps, and then from another port enter the micro scissor and then cut it. You can see, and still it's not dilated. So this is another way to make little bit the pupil dilated by stage pupilloplasty with the help of this Y-shaped Sinski hook. with orthogonal direction in all around. So you can see the pupil dilated further. You can stain it and do the complete. This much is sufficient to dilate the pupil. Rest of the procedure you can perform very easily. The only things with this kind of pupil, and this is very important. The bimanual technique is very important, in which we have to this lift one part, then little bit gradually rotate all around, so the nucleus will come automatically in the antechamber. You can see. So the main problem with stitch appropriate other pupil expanding devices there. There's some micro inspector tear may be there, that may lead to the permanent pupil dilatation. But in this case, I just only in two direction I have just done the pupil stitch pupil. You can see this another very small pupil with white cataract, and this after the staining it I have just that I have to use the pupil this independent devices, that's a malignant ring. As is very popular in case of phaco, but you can do also in the SICS. So you can engage with the help of CSQ hook to at one during insertion two port is engaged very well, and then again you can see how easily. So you can avoid lot of entry if you use the iris hook lenses. So it is also these devices is also helpful. People spend the devices which may be virus type, maybe Gupta's ring, this Malung ring. So in the whole procedure you can watch that the ring is not going to expand, and then usually how the pupil in the whole the procedure it is the pupil is well dilated, and then you can after you can implant the this IOL and just disengage the from all the side, and then you can remove with the same this injector, and you can see again the pupil comes to the normal, rather small pupil, and then another case is you can see how again in this case the latter pupil membrane synechia is there again. In this case, until this hampers the pupillary dilatation, it is important to remove the, break the synechia and remove the pupillary membrane all around. So with the head, take the help of the micro scissors, interpret the side port, and cut all around. This only the pupillary, along the pupillary border, just remove it. You can see whole the pupillary membrane is removed. Then after staining, it's very important. And then in this case, you know, in earlier case, if you use any expanded devices, the micro TS will takes place. In this case, if you use the, this is my innovative technique, pull and push method. The expose the site where you are doing any procedure, either capsule this rexis or other procedure. So how you can, with such a small pupil, you can make the larger size of the rexis with such a small pupil. This is my innovative pull and push method. So it is not going to disturb the pupillary margin much. And you can see the pupil is still round. There's nothing much difference. You can see another case of this small pupil, rather semi-rigid pupil. And this guy just decided to use very simple. This is the Gupta's ring, very economical. This is the ring, and you can see you can implant this ring. You can engage slowly. So it at least prevent the entry of various parasympathetic with the, if you are doing the using the iris hook lens, you can see it takes hardly 1 minute to engage how people can be dilated. These devices are useful also in the phaco, and similarly you can in the SICS also you can use in such a small people. But one thing that if you use any kind of these pupil expanded devices, if it is small pupil is some kind of micro, this inspector may be made tear, and what happens, the pupillary margin may become irregular. But anyway, there is no any option. Then you can do, you can see in the whole in the whole procedure, pupil is sufficiently made, is expanded, dilated. So this procedure you can perform very well. So these are the various devices you can use. Just my presentation just to show different kind of procedures. So whatever you suits you are comfortable, you can adapt that. But the main thing, the surgery should be successful without any complication. So these are the important things you have to remember. And then again, with the help, you can remove, disengage, and from all the sides, you can see, just pull it and disengage the iris. And with the help of only this forceps, you can hold it, you can remove very easily. But in this case, you can see there is some this inspector just takes place. But anyway, this is the picture post-operatively. So ultimately, I would like to say a last case, in which this is small scenario rigid people. If you any expanded devices, issues pupilloplasty, or as Dr. Kamaljeet told that this inspirotomy, then definitely it will disturb the shape of the pupil, function of the pupil. So I decided this is my own only technique. Just watch how you can just again the press another side stitch, and you can do simultaneously, you can do the rexis. So if you stretch the pupil in one direction only at a time, it's not going to damage the pupil much. You can see then now I am using the this curved hook, and you can just pull it in this direction, and gradually you can proceed all around. And then again with the Y-shaped hook, I press another periphery and expose the side, and you can see in this how this much size is. You can do the rexis. And then bimanual technique. In this case, bimanual technique is very important, as rotate the nucleus. And in bimanual technique, you can just pull it and just slightly lift it at one point. Then gradually rotate it, and the movement is slightly lifting movement. Rotating and slightly lifting, such a small pupil, how you can remove this nucleus. And then you can watch, you can see the pupil is circular. Hardly there's no cushion of any damage to the inspector by this technique. And you can see the pupil picture, the post-operative in a small pupil. This is a way that you can do in any case. Thank you so much for your questions.
Thank you so much, sir, all the co-instructors, and Professor Lahane, Professor Malik, Professor Ruchi, Professor Ragini, Professor S.P. Singh, and Pranav. So we'll have a photograph there. Thank you so much.
चलिए